The constant circulation of blood throughout the body is critical to life. It is the pumping of the heart that provides the force needed to move blood through 60 to 100,000 miles of blood vessels, thus allowing for the exchange of gases, nutrients, and wastes for the trillions of cells in our bodies. The heart acts as two side-by-side pumps. The right side, responsible for pulmonary circulation, pumps oxygen for blood from the body to the lungs. The relatively lower pressure in the right side of the heart protects the delicate tissue of the lungs and allows the thinnest possible barrier between the air in the lungs and the capillaries. At the same time, the left side pumps oxygen-rich blood at higher pressure to the body via systemic circulation. The heart has four distinct chambers. The upper two chambers, the atria, constantly receive blood. The lower two chambers, the ventricles, function as pumps to provide the force needed to push blood through the system of vessels circulating throughout the body. The direction of blood flow through the heart is maintained by four one-way valves. The atrioventricular valves prevent blood from flowing back into the atria during ventricular contraction. The semilunar valves prevent the flow of blood back from the pulmonary trunk and aorta into the relaxed ventricles. When heart valves close, vibrations occur within the ventricles and blood vessels that can be heard through a stethoscope. The cardiac cycle has 5 phases.
It gets more advanced, and we'll get there, but right now we're not there. So, straightforward. Nice to see it moving in context. Atria, ventricles, valves. We talk about valves today, and we move on to arteries and veins. Now, the organization of the valves and the chambers of the heart is largely due to some framework. The framework in the heart is a skeleton, quote unquote, but not a bone skeleton like we're used to. This is a fibrous skeleton. And this is a series of dense connective tissue rings that merge with the interventricular septum, the wall between the ventricles. And this dense connective tissue helps to maintain the original shape of the heart. It's the foundation upon which the valves will seat themselves, where they originate. And you can see the 4 fibrous rings shown here. They're named for the valves that they encircle. Those 4 rings are connected together, and then they're sitting on top of the interventricular septum. And so this fibrous skeleton helps to protect the valves, protect the structure of the heart, and return it to its original shape. It also provides an attachment point for the muscle of the heart. We learned last year that muscle contracts and shortens. Cardiac muscle is no different. And as it shortens, it brings 2 points closer together. But what are those points? There's no tendon and bone in the heart that are brought closer together by contraction. The heart contracts in a complicated spiral squeezing pattern, but the anchor point is largely this fibrous skeleton. It provides connection for the muscle of the heart. And we see the valves seated here nicely, the bicuspid on the left, the tricuspid on the right, in their orientations with the edges of the cusps meeting up properly. Same with the semilunar valves. And it's the role of this fibrous skeleton and these fibrous rings to maintain that shape, prevent deformation of the valves, stretching, and damage to the heart valves during normal use. Lastly, what's not obvious here is that this skeleton has a very important role in conducting electrical signals through the heart. It's not conductive. It's a very good insulator. Muscle conducts signal quite well. Nerves conduct signal quite well. But dense connective tissue is an insulator. It prevents the passage of electrical signals, which we will see is very important. We want electrical signals to pass through the heart, but we want them to do so in an orderly manner. We don't want them just to pass from the atria to the ventricles willy-nilly. They need to follow a specific path. And that will be laid out in detail in lab next week and in lectures over the next week and a half. So this fibrous skeleton helps to insulate or direct the electrical signals properly. We'll see that coming up. Now let's spend a little bit more time discussing the valves, because they are what allows for directional flow. The heart can conduct electrical signals and beat all it wants to, but without the valves, there's no directional flow. And all valves in the heart open and close in response to pressure changes. And what I mean by a pressure change is the creation of a pressure gradient. So much of physiology is gradients. Here, if there is a high pressure in one area and a low pressure in the other, pressure distributes from high to low until they're roughly equal. Same with concentration. This can be applied to movement of molecules or pumping of electrons in the electron transport chain, the movement of air in the lungs. So much of physiology is gradients. Here, we're focused on pressure specifically. So the valves open and close in response to the creation of a pressure gradient. I'm going to harp on that. That's important. We already know the atrioventricular valves separate, it's in the name, the atria and the ventricles. These are also called the cuspids, the bicuspid on the left-hand side and the tricuspid on the right-hand side of the heart. The bicuspid is also called the mitral valve. And the whole point of having these valves is to make sure that blood doesn't flow back into the atria during a heartbeat, during contraction. You can see these depicted on the right, and we went through some of the structures that support these valves in class on Tuesday. You remember the name of these long strands that connect from the edge of the cusp to these meaty pillars of muscle in the ventricle. They were called chordae tendineae. And the pillars of muscle were the papillary muscles. You've seen that in lab, we heard that in class. Those are common structures associated with the AV valves. The other major valves are the semilunar valves, and they regulate exit of blood from the heart. They allow flow of blood from the ventricles into the arteries, into the vessels leaving the heart. The pulmonary trunk or the pulmonary arteries on the right-hand side, and the aorta and the rest of the vasculature on the left-hand side. These ones don't have many associated structures. They're semilunar, they're curved like crescent moons. They open and close like little pockets. And we'll see how pressure itself seats these cusps, seals the valves. We don't need chordae tendineae and other muscles to seal the semilunar valves. Of course, these are named for the vessels into which blood flows, either the pulmonary valve on the right-hand side or the aortic valve on the left. Now, I want to explore this idea of pressure change. And you don't have this slide, and I did it on purpose. One, because the animations are long and complicated, and to have all the arrows sitting there doesn't mean much to you. But I want you to think about how pressure would drive flow. This is any vessel. It could be the heart. There are 3 roughly distinct chambers, and they're separated here by valves. And that's what these little doorways are meant to represent. So blood flows in response to the creation of a pressure gradient. I'm going to make high pressure on the left-hand side. High pressure on the left-hand side. What happens if blood in this section is pressurized? Pressure simply means the blood is being pushed outwards in all directions. Or force is trying to escape in all directions. And if there is an avenue for escape from high to low pressure, the blood will move accordingly. Here, it moves through this valve. There's a small opening. Blood flows from a high pressure to a low pressure. In doing so, it pushes this valve open, and we have unidirectional flow. I'm assuming that the left-hand side here is closed off. There's no escape. And that should be fairly common sense, should be intuitive. What happens if I make high pressure in the middle? If somehow this middle compartment is pressurized? The blood is trying to escape in all directions. It's going to try to push on the valve to the left. And as it does that, this valve closes. So do we get flow through this valve? No. The blood hits a dead end. There might be some reverse currents, but it can't escape that way. Pressure is not relieved. This compartment is still pressurized. But the blood is looking for escape in 360 degrees. We have a valve over on the right-hand side that can open. Blood moves from a high pressure to a low pressure, and so it flows towards the right. This is important. This is how we achieve unidirectional flow. And successful functioning of the cardiovascular system is based on this concept, unidirectional flow. You don't have this, you don't survive long. You can't get oxygen and nutrients to where they need to be. This is the idea underpinning unidirectional flow. So what I've described here, we can imagine pretty easily if we look back at the valves in the heart. That long tube could have been atrium, ventricle, aorta. Notice here on the left-hand side, the valve is open, which means there must be a higher pressure in the atria, in the atrium, than there is in the ventricle. And when the valve is open, that is true. That's the case. There's a higher pressure in the atrium than in the ventricle. The valve opens, blood flows through. Notice the chordae tendineae are slack, and the papillary muscles are relaxed. You don't contract those muscles to open the valve. The pressure difference does that in and of itself. But something happens with every contraction, with every heartbeat. The heart squeezes, the ventricle contracts, and pressure inside the ventricle goes up. As soon as that happens, we're in scenario 2 on that last slide. Blood's trying to escape in all directions. It pushes back up against the bicuspid valve, which closes the valve, preventing flow back into the atrium. No escape. Blood cannot flow backwards within the heart, which is good. It's not enough that we have a high pressure and the valve closes. There is enough pressure, and this valve is delicate enough that if we didn't have a support structure, blood could push through. It would blow this valve back into the atrium. This is where the support structures come into play. This is where the papillary muscles contract. The chordae, tendonae are taut, and they anchor the seam between the cusps of the bicuspid valve. Preventing eversion, or the backflow of blood into the atrium. This is where the support structures come into play. They contract to prevent movement of a valve. Now, a very similar principle applies to the semilunar valves, even though they don't have support structures. And you can see them here. You can see one in action in the top right. It opens and closes in response to the creation of a pressure gradient. So, my question to you, as this opens and closes, when it's open, where is the higher pressure? Is it behind the screen, away from you, or is it in front of the screen, towards you? Any guesses? And the pockets are facing out. They're concave facing you. So where's the higher pressure when it's open? You have an idea? No? Pardon me? Behind the screen, absolutely. Pressure is higher behind the screen. Blood pushes its way past the pockets. They flatten against the inside of the wall of the aorta. And blood flows out. Lower pressure on your side, higher pressure on the other side. And so then when the semilunar valve is closed, the opposite must be true. Higher pressure in the arteries out here, lower pressure behind. The blood tries to push its way back, but the pockets act like a parachute, and they catch the blood before it can go back into the ventricles. And it's actually the fact that these pockets catch the blood that seals this valve. As the blood pushes its way into the pockets, it also pushes the lips of the pockets together. It tightens the seal between these cusps. So in fact, the greater the pressure gradient, the more the blood is pushing these pockets together and the less backflow there is. The higher the pressure gradient, the better the seal. The smaller the pressure gradient, the worse the seal, but it doesn't really matter because with a low gradient, there's not much flow. And we don't ever see that in practice. Does that make sense? Pressure gradient dictates whether the valve is open or closed, and the valves allow or make for unidirectional flow. Very important concept in the cardiovascular system. So this is simply a real view of the valves, a cross-section through the fibrous skeleton at the level of roughly all four valves. You can see the fibrous rings. We have the cuspid valves on the bottom, the bicuspid on the left, tricuspid on the right. Notice the rings are fairly obvious, but not too well defined in some cases. Also notice the seams. Remember we talked about the idea that the bicuspid valve only has one seam down the middle. Fewer moving parts, less room for error, less likelihood of backflow, versus the many seams in the tricuspid on the right, lots of points of potential failure, but it still does a pretty good job with the lower pressures on the right side of the heart. And the semilunar valves here with the obvious pockets pointing out into the vasculature that catch the blood, preventing it from flowing back into the ventricles. So we know why valves open and close. We've seen examples of how. Let's consider the order, the relationship between the operation of these valves. Now these slides say that when one set of valves is open, the other set is closed. And what's certainly true is that both sets are never open at the same time. That's absolutely always true. This is usually true. One is open, the other's closed. There's a certain point where this isn't true, and I'll talk about that, I'll bring that up at the end, but usually if one set is open, the other is closed. So in this case, the atrioventricular valves are open, the semilunar valves are closed, and if you reason this out, it means the lowest pressure must be in the ventricles. There's a higher pressure in the atria that are opening those valves and allowing blood to flow in. There's also a higher pressure in the vasculature, which is trying to push blood back into the ventricles, but the semilunar valves are doing their jobs. They're closed, catching the blood so that backflow is not possible. The lowest pressure must be in the ventricles. So one set is open, the other set is closed. This rule holds up. We don't know anything about the cardiac cycle yet, so I'm not going to ask you when that happens. And indeed, it is also true that when the semilunar valves are open, the atrioventricular valves are closed. So again, usually this is true. If one set's open, the other set's closed. A slightly different scenario here. The lowest pressure is not in the ventricles. We know that because, one, the semilunar valves are open. Two, the atrioventricular valves are closed, so there's pressure pushing against those valves, and that pressure can only come from the ventricles. Here, the lowest pressure is in the atria. The lowest pressure is in the atria. Now just think, does that make sense to you? It should. I don't think it's wrong. No, it's not wrong. It should make sense, but it's a somewhat tricky concept to grasp. The lowest pressure must be in the atria. If the AV valves are closed, that means there's a higher pressure in the ventricles seating them, closing those valves. If the semilunar valves are open, it means there's something pushing those pockets flat against the inside walls of the vasculature. There's pressure coming from behind the screen, and the ventricles, in this case, are behind the screen. Highest pressure in the ventricles, lowest pressure in the atria. Now this is interesting. We're going to see this in more detail in the coming weeks, but the ventricles are kind of cool when it comes to the cardiac cycle. On the last slide, they had the lowest pressure. On this slide, they have the highest pressure. And not just in the heart, but in the entire cardiovascular system. The ventricles cycle between lowest pressure and highest pressure, back and forth with every beat. I'll explain why in a second. But because it goes between those extremes, there's a point in the middle where it's transitioning. where it's between the pressure in the arteries and between the pressure in the atria. In that case, both sets of valves are closed. I don't expect that to make a lot of sense now, but keep that idea in your back pocket and think about that as we move forward and talk about the cardiac cycle and the injection of blood. There is a point where both valves will be closed. A good exercise might be to try to reason amongst yourselves when that might be. So you should be well equipped at this point to run through this slide on your own. We've discussed surface features. We know chambers of the heart. We know the main internal features and how valves work. You should be able to trace the flow of blood through the heart, which is exactly what this slide is doing. The flow chart on the right and the diagram on the left, the numbers match up, so you can match the numbers to each point on the diagram. A really good learning progression might be to just read through this slide, then take the flow chart away and describe this picture, and then try to take the numbers away. Just find a blank picture of the heart and see if you can teach one of your peers blood flow through the heart without the flow chart and without the numbers. That might be a good learning progression for midterm number 1, perhaps. I'm not going to go through it in detail here. I could, but I feel like that just will take a lot of time. We've already touched on all of these elements. You should know them. They are in order. Note a couple things. Unidirectional flow. Flow is in series. One point, there's a cause and effect relationship. One point leads into the next, and so on. And we'll talk about pulmonary circulation later when we talk about the lungs. Right now, magic happens as blood leaves the pulmonary arteries and then comes back in the pulmonary veins. This describes what the heart does with every single beat, and the goal being supply the tissues of the body with oxygen, supply the tissues of the body with nutrients, carbohydrate, fat, etc. What we often overlook, though, is that the heart is one of those tissues. We can trace blood through the chambers of the heart, opening and closing valves, but nowhere in that discussion does the cardiac muscle tissue receive oxygen or receive fuel. The heart is one of those tissues that needs oxygen and fuel to operate. And the coronary circulation is a brief tangent in this section, but is what is responsible for supplying the heart with oxygen-rich blood. The heart needs blood supply. So you probably saw these in lab. The coronary arteries are branches off of the aorta that are responsible for doing just that, supplying the heart. And they are the first arterial branches off of the aorta. They are absolutely the first. They arise off of the aorta as it ascends out of the left ventricle. You can see them here. And they wrap around the pulmonary trunk. All of the red squiggles are arterial branches. So oxygenated blood, nutrient-rich blood, going to the cardiac muscle tissue. And the blue squiggles are veins. Arteries deliver and veins drain blood from a given tissue. So like we have coronary arteries, the coronary veins will drain waste products, drain CO2, and return it to the right side of the heart for mixing oxygenation, and then circulation again. We haven't talked a lot about the veins on the heart proper, and one of the surface features that I purposefully overlooked at first is the coronary sinus, which you've probably also seen in lab. It's a very noticeable feature on the back of the heart. All of the veins in the coronary circulation drain into the coronary sinus. Let's take a quick walk through this circulation. In order for there to be circulation, there needs to be a pressure gradient. We need to have flow into the coronary arteries. And conveniently, these branch right off of the aorta, and the entry point is essentially in two of the pockets of the aortic valve. So as pressure in the arteries shuts that valve, opens up those pockets so they clamp together, blood flows into the right and the left coronary arteries. The inlets are in the pockets of those valves. And these are the two most obvious initial parts of the coronary circulation. The right coronary artery will descend along the right border, and there's two main branches. The first is the marginal branch, which, because of its name, or it's named according to its route, it travels along the right border, or the right margin of the heart, supplying the right ventricle. And it loops all the way around the back of the heart, becoming what's called the posterior interventricular branch. And you might have used these as landmarks when you were looking at the surface anatomy of your heart. There were two sets, one on each side, the front and the back, of veins that ran right down the middle, almost towards the apex. And on the back, it's a little bit smaller, the posterior interventricular branch running in the posterior interventricular sulcus. It's a very fat-laden groove on the back of the heart. So the right coronary branch supplies the right side and a lot of the posterior aspect of the heart. The left coronary branch supplies the left side of the heart mainly. And I think one of the most defining features, or easy to distinguish features, is this anterior interventricular branch. Simply means it's a branch on the front that runs along the wall or the division between ventricles. This was an obvious line down the front of your heart that ran almost right to the apex. This supplies the wall, the anterior aspect of the wall of the heart, as well as the left ventricle. And there are many more divisions that aren't included here, but you can see that the supply is widespread. And in a lot of cases, it's redundant. There are many branches supplying these areas, but they're too small to be seen here. On the return side, if we consider those as our main branches of the coronary arteries, after delivery of oxygenated blood, it needs to be drained from those same tissues, and the venous circulation, the venous coronary circulation, is responsible for that. You can see the coronary sinus along the back of the heart, shown here. This large, cavernous receptacle that collects all of the blood returning from the heart tissue proper. And if we return to some of the figures that we saw earlier in this set of slides, you can see it shown here along the back of the heart, just inferior to the left atrium. And this might be a little bit small, but you can see the opening where all of that blood spills out directly into the atrium. So the large majority of blood from the body arrives back at the heart through the vena cava. But the one small exception to that is that blood returning from the heart proper arrives to the right atrium through the coronary sinus. Every other tissue, every other structure, all the other blood from the upper body, from the lower limbs, returns to the heart through the vena cava. Blood from the heart comes through the coronary sinus. And there's a little opening that you can see right here if you look closely, where it empties into the right atrium. Now that well-defined artery on the front runs with a corresponding vein. It could be the anterior interventricular vein, but we call it the great cardiac vein. It's the largest vein on the heart, draining the heart tissue. Makes for an obvious venous drainage that you can see on the heart, running in line with the anterior interventricular branch. Its corresponding vein on the posterior aspect is what we call the middle cardiac vein. And this meets branches from the right side of the heart, the small cardiac vein slightly superiorly, and the anterior cardiac vein, which drains the section provided or supplied by the marginal artery along that lower right border. There are many more branches, and I want to impress upon you how well vascularized the heart is. This is not that impressive. We have large arteries going to the general locations that supply most of the tissue, but in actual fact, the vasculature of the heart looks like this. Look at how well perfused the cardiac muscle tissue is. Many more branches. The anterior interventricular branch is prominent in this figure. You can see that here. Many divisions, many tiers and layers of divisions, and I want to impress upon you the highly vascularized and how well perfused the heart tissue is. It has an incredible arterial supply. And this is made through a technique called plastination. It's the same technique that a lot of the Body Worlds folks will use to make some of the models that they put on display, where you can inject a special resin into a large artery that will filter down into all the tributaries of that artery. And then you take the organ and you dissolve it. You dissolve all the tissue, all the fat, the walls of the arteries, all of the organic matter gets dissolved away, and you're left with the resin. And so that's what's been done in this case. Resin was pumped into the aorta, and it filtered down through all of these arteries and all of the tributaries, filling all of the vasculature of the heart. And you can see how densely packed those small arteries are. Which makes sense, right? You need this kind of supply. The heart has what we call a constant duty cycle, which simply means for as long as you're alive, your heart beats. It's always contracting, resting, contracting, and it can't stop. It needs a constant supply of oxygen, constant supply of nutrients, and redundancy. If any of these branches is ever blocked, if a smaller one is blocked, then there might be other tributaries that can make up for and supply the tissue that's distal to that blocked branch. If it's a larger branch, then you're in trouble, but we won't talk about what that trouble is necessarily right now. We do talk about that in clinical exercise physiology in depth, which is pretty cool. That's in your 4th year though. So let's leave it there. We'll come back to class tomorrow with a big discussion on blood vessels, and we'll try to trial some turning point questions and quizzes. Have a great Thursday.